Welcome to the satellite meeting, Integrated Prevention Campaigns, Evidence for Impact and Efficiency, Global Potential and Sustainability. I am Jim Kahn from the University of California, San Francisco. We're pleased that you could be here. We have three panels. The first will talk about the results of the first campaign in Western Kenya and some new data from Judd Walson on clinical effects of bed nets and filters. The second panel will examine the potential for the scale-up of the integrated prevention campaigns, and the third panel will look at sustainability and policy issues.
I've known Jim for over 20 years. He's done wonderful work. The work you're going to hear about now, we feel is the future. You're going to hear a lot of wonderful things. Feel free to think out of the box and ask any and all questions you want. It's a real honor to be here. And I want to introduce my colleague, Dr. Wilson Compton, who is the director of my division, the Division of Epidemiology, Prevention, and Services Research, who feels kind of the same way we do, but I want to give him some time on the spotlight. Thank you.
Thank you, Peter. Thank you, Jim. And welcome, everyone, on behalf of the National Institute on Drug Abuse. I'm very pleased to be here and to be able to express some appreciation for the terrific modeling work this panel represents. And you know, there may be a natural question: how come a panel on the impact of malaria, tuberculosis, HIV, or similar non-drug use related efforts would be supported by the National Institute on Drug Abuse? Well, partly because the work that Dr. Khan represents has included drug abuse over the years, that this modeling work has naturally extended to some of these new areas. But one of the key reasons that we've been interested in this and have recognized its importance is because drug abuse is usually a hidden or secondary epidemic and a secondary issue. It's very rare that we can get governments, policymakers, or practitioners to directly deal with drug abuse. So it's only by embedding drug abuse in larger scale efforts that include multiple efforts can we make a dent in drug abuse from a public health perspective. So these integrated prevention campaigns have tremendous implications for how we can address drug abuse in multiple settings. But in particular, we want to learn as much as we can for this particular effort to be implemented in East Africa and to see how it can be taken to scale and learn from these efforts and see how they may apply to both these particular conditions as well as many other health conditions internationally.
The first panel will be chaired by Ruben Granich of the World Health Organization. Ruben and I have worked together on issues about expanding access to ART, which is an issue that is very relevant to this, and we're extremely pleased that he's willing to chair this first session. Thank you.
Thanks for that great introduction, Jim, and thanks everybody for showing up. It's clear that this is a really important area, and at WHO we've been working on this for quite a while, actually, or a few years. The interest grew out of our increased interest in treatment as prevention, and the idea that the major problem that we're facing, which is that a majority of people don't know their HIV status. And so when we were thinking about how to get into the community and how to reach people, it was clear that the work on community-based multi-disease prevention campaigns was a possible answer to that question. And so I think we have a very exciting set of panelists here, and I think for those of you who are familiar with the work, you won't be blown away as using California lingo. But for those of you who haven't seen this sort of work, I think you'll be just like I was when I first heard about it, and you'll be very, very impressed and realize that this is probably what we're going to be talking about today is probably something that you're going to see a lot more of in the future as we move our targets up for getting people onto treatment. And now you already heard, and you'll hear tomorrow morning in the plenary, that we're already thinking about 23 million people who need to be on treatment. And that, I think you'll see over the next few years, that number is going to move very quickly up to 32 million. And to get there from here, I think that you're going to hear some of the answers from the panelists and from this session. So I'm really glad that you're here. I'm sorry I speak so quickly, but I want to get to our panelists. With no further ado, I think it would be good to hear from, I think the first person on the panel is Eric Lugata. And Eric is with Axios in Nigeria, but before he was the lead person for the Kenyan campaign, and he's going to describe in detail that experience there. And I think you'll be impressed by his presentation. So thanks, Eric, if you come up.
Good evening, ladies and gentlemen. I'm going to just take you briefly through the way we implemented this campaign in Western Kenya in Rurambi Division. We all know that HIV is critical. Diagnosing HIV is critical for preventive and treatment efforts. And also it's critical for us to address co-infections such as malaria. If we address malaria, diarrhea diseases, we can delay the progression of disease, including, of course, tuberculosis. But we also know that preventive interventions such as long-lasting insecticidal bed nets, point-of-use water filters, condoms, and HIV counseling and testing, when implemented on a large scale, can reduce malaria, diarrhea, and the incidence of HIV in large populations. We also know that multi-disease prevention campaigns can achieve rapid and high coverage at low cost, but these hadn't been widely applied or evaluated in combination with HIV testing and counseling as a preventive option. The integrated prevention campaign was a 7-day campaign which was held in Kenya, in the western province of Kenya in September 2008. And we aim to combine voluntary counseling and testing as a preventive option. We distributed a care pack which contained bed nets for the prevention of malaria, water filters for the prevention of diarrheal diseases, condoms as of course part of preventive efforts for HIV, and education materials on how to use the commodities and as well as preventive messages. The campaign mobilized stakeholders right from village elders, including the local provincial elders and the local hospital leaders, and it was implemented in 7 days. And the aim then, we were intending to test the feasibility of covering at least 80% of the population that was aged between 15 and 49 within 7 days. We conducted a post-campaign survey 2 months after the campaign to measure the uptake and utilization of the products that we distributed during the campaign. We also included a qualitative analysis evaluation to find out circumstances and see if this campaign had any negative effects. Particularly at the time, we were worried about the women because some people thought it could result into negative effects of domestic violence if they participated in the campaign. And then we also conducted a cost and cost-effective analysis to assess whether the campaign was worth all the effort that we invested, both in terms of finances and in terms of skills and people that were involved. The micro planning included getting a buy-in from the Ministry of Health, district health authorities, the community, and people living with HIV and AIDS in this community. We mapped the community and selected 30 sites which were uniformly distributed in Rurambi Division so that we could bring the services closer to the people in that region. We were able to recruit and train over 600 personnel to do various tasks. They included HIV counselors, they included laboratory technicians and product demonstrators. And this was a task which we did for about 30 days. We conducted HIV counseling and testing following Kenya National Ministry of Health guidelines, and we obtained consent as well as filled the national VCT form. So we made sure that we do not disrupt the existing national systems for conducting HIV counseling and testing. We did parallel testing at the time, and we also integrated quality control by sending 10% of all the samples that we tested in the field for dry blood testing at the CDC laboratories in Kenya. We mainly conducted group counseling consisting of approximately 20 individuals who were educated. They received health education across all the 3 diseases, preventive education concerning all the 3 diseases, and instruction on how to use the commodities that were included in the care pack. We also included a point of diagnosis CD4 cell counting at the time to make sure that we were able to assess patients who needed to be started on treatment or given further care at the time when we tested them to be HIV positive. And at that time, we also distributed a 3-month course of cotramoxazole, which we all know was relevant to keep people who are HIV infected longer, healthy and longer. And then we referred those who are HIV infected for further care to nearby hospitals. This was the process of the campaign. We started with a pre-campaign. If you look to the left side is that the left? The right-hand side of the slide, we started with social mobilization, public health education messages through newspapers, and all sorts of media campaign at the community level, and also putting up road shows and all community events to try and encourage the community to participate. And during the campaign, we had, in all the 30 sites I mentioned, there were actually 31. The 31st site was a mobile Chusi HCT center, which was provided by CDC. In each of the sites, we had a product demonstration area, we had a pre-test counseling area, we had a registration area, and at the registration area, the individuals were given an option to opt out or to opt in. If they opted in, they were tested for HIV. If they were found to be HIV test positive, they were referred for further care. And if they were HIV negative, they were given the commodities and of course given all the material, but everybody received the commodities, including those who opted out of the testing. And the campaign flow, we had clients follow up after the campaign, post-campaign, including an analysis, which I mentioned earlier on, 2 months after the campaign, plus care for those who are HIV infected. And I think a clinic was set up in this center to continue to provide care for those patients who are identified as being HIV positive. That's just a pictorial of the events of that day, some of the events during that day. And the results, this is just a summary of the campaign itself. We targeted close to 50,000 individuals who were aged between 15 and 49. We tested a total of over 47,000 individuals. 80% of them, that's over 80%, which was a target we set ourselves for. We diagnosed almost 5% women who were HIV infected at the time, and the men accounted for about 2% or 3% HIV positive. The lowest HIV prevalence was within the ages of 15 to 19, and the highest was in the ages of 30 to 39, which was almost close to 7%. And all those, over 96% of those who tested HIV positive were given Cotramoxo prophylaxis at the time of finding out their HIV status. In conclusion, we found that it's feasible for us to address multiple health problems simultaneously in a short time, thus achieving some of the objectives of the MDGs in an efficient way. And we believe that if we expand this, we can be able to achieve more of what MDGs are aimed at trying to achieve. We were able to reach universal testing in a very short time, and also to get the patients who needed to be started onto care at the same time through point of care diagnosis, CD4 count, and starting cotramoxazole, as well as referring them for care. We also discovered that we were able to break the myths which were associated with social barriers such as HIV testing stigma, because the community embraced the exercise, and the women who we feared might face domestic violence didn't actually get any of those. We were able to achieve, at least for the first time, universal coverage with bed nets, water filters, at the same time addressing both malaria and diarrhea diseases, which resulted in a decline of these diseases, which we know in Kenya cause high morbidity and mortality to that population. And definitely we were able to get people early in the HIV infection, because we were testing healthy individuals who are not sick. Most people go to hospital when they are sick. That's when we discover they're HIV infected, and yet we know if you identify them early and start early treatment, you avoid any debilitating effects of the HIV infection. And with further analysis, which will be presented later, there was a significant decrease, economic saving, and significantly in this population. And then above all, we are able to contribute to strengthening the health system, because it involved the Ministry of Health, the local leadership at the community level, and the local hospitals and healthcare centers within this community, as well as the 600 individuals who apparently were mainly from this community, who benefited from additional skills that we imparted within a very short time. Thank you.
The goal of our analysis was to estimate the cost, the Thank you. The health effects and the cost effectiveness of the diarrhea, malaria, and HIV integrated prevention campaign as implemented in Laramie, Western Kenya, September of 2008. Our data sources for program costs, we did an empirical analysis of the campaign as implemented, plus we modeled a scaled-up replication by estimating what inefficiencies could be removed. For the health effects, the deaths and DALYs averted, we used published trials and meta-analyses and then disease incidence modeling. The costs of medical care incurred and averted was derived from published studies and databases. We found that the program cost $42 as actually implemented. Our scale-up replication estimate, which involved less intensive staffing and total reliance on Kenyan salaries and not anyone from other countries, resulted in an estimate of $32 per person, per participant in the campaign. Fortuitously, a second campaign, a smaller one, was done, which actually ended up having exactly that cost, so we felt that our estimates were pretty good. Of the $32, $16 was attributed to the malaria intervention, the most of the three due to the cost of the filter. Malaria cost $627, including the bed net and the portion of the labor, and then HIV, VCT, including the COCHAM, cost $992. When we estimated the health effects, we first looked at deaths averted. Again, this is based on a review of the literature of the effectiveness of these interventions. For diarrhea, we estimated 6.8 deaths averted, which translates to 191 DALYs averted. For malaria, 4.3 deaths averted, 125 DALYs averted. For HIV, particularly the VCT component and the behavior change in positives, as well as the distribution of condoms, an estimated 5 deaths averted, 42 DALYs averted. We also looked at the DALY effects of referring people to care, in particular to earlier ART care and a higher prevalence of ART care by identifying people with HIV, and found that that contributed about 82 DALYs to the total. So the grand total for all of these pieces was about 442 DALYs averted. For the costs, there were substantial savings from the prevention elements. The estimated savings due to diarrhea episodes averted and deaths averted was about $48,000 per 1,000 participants. For malaria, about $10,000, and for the prevention component of HIV, about $25,600. The added use of ART due to finding more people who were infected actually increased the cost. ART is expensive, and that added to the cost of by about $37,000. Taken entirely together, the offsetting savings from all of these considerations was about $48,000 you see in the bottom right. This means that the campaign cost estimate was $32,000 per 1,000 people, and if you take away the $48,000 in offsetting savings, you get an estimate of $16,000 in net savings. In that context, no cost effectiveness ratio needs to be calculated. In conclusion, we found that a mass, rapidly implemented integrated prevention campaign for HIV, malaria, and diarrhea in Western Kenya in that setting provides substantial health benefits in terms of deaths and DALYs averted, and also appears to be economically attractive, indeed cost-saving. Thank you.
Thank you. So in addition to the obvious benefits to preventing diarrheal disease and malaria that you can incur by distributing these commodities, there's also the question of what the impact might be on those individuals, whatever proportion of the population that you do identify who are HIV infected. And brief mention has been made of the fact that earlier diagnosis allows earlier treatment with antiretrovirals, and that may be beneficial. But we were also quite interested in looking at the question of whether putting people with HIV on care, such as the use of a bed net and a water filter, would reduce the progression of their HIV disease. This has huge, enormous public health consequences, given that when we go into most African centers, fewer than half of the people who have HIV know they have HIV. Testing has been hard to get out to everyone, but clearly there was incredible uptake of the campaign and of distributing these commodities. And obviously, the impact of trying to roll out ART has been quite visible, and I think people realize that as much as we'd like to get everyone on ART, that hasn't happened as rapidly as we want. So if there are ways to delay the time until you need to start ART, that might be beneficial. And so there's some data that have shown a variety of different infections, such as including malaria, are able to raise the viral load in patients infected with HIV, and that some studies have suggested that treatment of infections such as malaria or other intestinal infections may actually reduce viral load. And the question is, and I think this was brought up in an earlier talk today, what is the impact of such small reductions on viral load, such as been seen in many of these studies, where people are talking about half-log reductions or quarter-log reductions in viral load. And here's just a couple of studies which have shown fairly substantial reductions in both transmission and progression with very minimal changes in viral load. And this is a study that modeled out that effect in terms of time until you would meet clinical indication for antiretroviral therapy. And even with as small of a half-log reduction in viral load, you're looking at a year or more, sometimes substantially more, of time to progression to AIDS or needing ART. So this really was the backbone for why we thought that the provision of a bed net and a water filter to individuals with HIV may be beneficial in slowing progression. So the study objectives really were to determine whether or not this would happen, and we defined progression as time to a CD4 count of less than 350 based on current Kenyan guidelines for the initiation of ART and or death. And then we had some secondary endpoints which looked at incidence of malaria and reported diarrheal disease. We recruited patients through this campaign that you heard about and recruited them into 2 study clinics at Kisii and Kisumu hospitals in Western Kenya. The inclusion criteria are there and the exclusion criteria are there. I'm not going to read them all. We have a lot of panels to go through, so in the interest of time, I'm going to move pretty quickly through this. But if people are interested in more of the details of the study, this has been submitted for publication and will be coming out soon. But I'm happy to wait afterwards and talk to anyone about any more details. But the important things to point out are these are ART naive adults with CD4 counts greater than 350. So here we can see the study design, and I would first point out this was not a randomized trial. We did not feel at the outset that it would be ethical to randomize individuals to not receive a bed net based on current WHO guidelines. So instead what we did was we had one cohort of individuals enrolled who received a bed net and a water filter at these clinics. And in the same clinics, we had patients meeting the exact same criteria, we used the same inclusion criteria, who did not receive a bed net and a water filter as part of the campaign. And those 2 cohorts were followed prospectively in parallel. And you can see there that we followed, in the end we included almost 600 patients in the analysis and had a very, very minimal loss to follow-up. In those patients, they were followed for 24 months with CD4 counts every 6 months. So the first thing you can see that's quite striking is we asked after 1 year of the trial how many people were using different systems for water purification or bed nets. And one thing that's quite striking is that while the people who used the filter was quite high, of those who received it, 93% reported after 1 year still using it. We actually confirmed this by home visits and a subset of those and confirmed that they were not only using them but using them properly. And we had similar results, very high percentage of people correctly using and continuing to use the filters. But as you'll see, even though very, very few people in the control group used the filters, many of them did use other methods of water purification, which you can see there. But not, in some, it still didn't reach the 99.5% of those drinking purified water in the intervention group. Bed nets also is quite striking that even among those who didn't receive a bed net through the campaign as part of the study, there was still fairly high widespread use of a bed net even in the control arm. So again, this would potentially bias our results towards the null if these were working through the methods we thought. So the first thing I'm going to show, and again, just in the interest of time not being able to go into too much detail, the use of the filter and the bed net, and we are not able to separate the interventions and the effect of the interventions, they were given in combination, reduced self-reported diarrhea by 35%, reduced self-reported malaria by 25%, and reduced clinically diagnosed, and that was mostly through the use of rapid diagnostic tests, although when not available, smears were used by laboratory staff blind to treatment allocation group, but reduced clinically diagnosed malaria by 34%. So I think the first finding we had was they worked, they did the things they're supposed to do. And when we look at the impact on HIV disease progression, what we found was a reduction in the time to reaching the CD4 threshold of 350 over the 2 years of the trial. And that reduction, this is to time less than 350, and this is a combined endpoint of 350 or death. There were few deaths in the cohort, which we were very happy about, and so most of this was comprised of the endpoint of time to CD4 less than 350. So the combined intervention resulted in a 27% risk reduction in HIV disease progression, which is measured by time to a CD4 count of less than 350. So this would mean that essentially over the 24 months, an individual would save approximately 6 months of time off of ART, any one individual, and then pooled over many hundreds or thousands of patients, you can begin to see the potential impact of such a reduction. And that, again, is just the 2 years. That we didn't extend the trial beyond 2 years, but clearly if that benefit extends 4, 5, 7, 8 years, that would increase. And so that's that. The combined intervention resulted in a very similar 26% risk reduction in the combined endpoint, including death. I didn't include that here because it was so similar and was comprised almost entirely of endpoints related to the CD4 count. So with that, I want to thank all of the folks who made this study possible, in particular Ben Piper, who's here now and really helped coordinate these trials in Kenya. But thank you all very much.